Gentleman who had an alleged history of blunt abdominal trauma 14 days back, present to emergency with pain abdomen, abdominal distension, with with vitals were unstable during that time, for which we did resuscitation, and also we did a routine investigation for which chest X-ray showed gas under diaphragm, and vital was not stable operatively, so we had to start on NORAD for this patient. Intraoperatively, patient had an perforation of 1 into 1 centimeter in the entire rectal wall, for which we did a primary repair of the perforation, rectal perforation, and diversion ileostomy was made for this patient.
Right? Why or what could be the etiology for the rectal perforation? The rectal perforation is not common, no? Rectum is very strong. So what do you think is the etiology?
So, and there is no history of any drug abuse or any other
foreign body, or the patient is not giving a proper history of
If the
of how
patient
he.
has some unusual history, that is
That is why I was asking.
Yes,
Actually,
sir.
in your
There was
history, you
no
can
such-
include that.
Yes, sir.
When you are presenting such a case, perforation of rectum is not something common,
on anterior rectum.
especially in the anterior rectal wall. While anterior would still have some peritoneal coverage, it's still protected. What would be the reasons for the rectal perforation?
So could be traumatic because of some abuse.
There is no trauma, yes, and abuse, that's right, one.
Yes, sir. So could be some psychiatric illness for which patient has some habit of inserting some foreign body that could cause. Sir, I can't think of anything else.
Junaid?
So, immunosuppressed patients, there might be solitary rectal ulcer which develop. It might, because of low immunity, the healing is poor.
So what is solitary ulcer syndrome?
So actually, it usually occur in the posterior rectal wall, sir.
It is associated with the mucosal prolapse also. It develops in the posterior rectal wall, and it doesn't heal with the conventional therapy. And the patient just present with the bleeding and no other finding. And on colonoscopy, we just it looks very suspicious of malignancy. However, when the biopsy is always negative, so it is a diagnosis of exclusion, the solitary rectal ulcer syndrome.
Very important. Now, what are the various theories for solitary ulcer syndrome? Never heard of it. The term solitary means it's alone. The rest of the rectum may be normal. And as you said, nobody knows the etiology, but it's a diagnosis of exclusion. It will exclude all the other causes of ulceration in the rectum. Now, what could be the various causes for ulceration in the rectum, Terry?
So one could be this solitary rectal ulcer syndrome. So then it can be malignancy. Other GIST can also cause ulcerations in the rectum. Crohn's
ulcerative
colitis.
Why don't we call it inflammatory
Inflammatory
bowel
bowel.
disease?
Yes, sir. Inflammatory.
Even MBBS can cause it, but MBBS doesn't happen low down in the rectum. Yes, Crohn's and ulcerative colitis can be an important factor. So you need to exclude conditions before we actually just sleep over it. It's a case of rectal ulcer perforation. Would it produce peritonitis?
Yes, sir.
But if it is extraperitoneal, why should it produce peritonitis? Yes.
Unless the perforation is the upper part of the rectum, which is covered by peritoneum.
So what would it,
then-
how would it present? The patient had gas under the
Pelvic
dome of
dialysis.
diaphragm, no?
Yes.
Yes, sir.
Patient had pneumoperitoneum. Am I right?
Yes, sir.
So then it has happened above the peritoneal reflection. Do you understand what I am saying?
Yes.
So perforation has happened
Above.
above. That itself indicates that it is above. How will the lower one present?
Sir, with the diarrhea or with fistulas, multiple fistulas, and pain, intractable pain, sir, during
It will
defecation.
have features of pelvic cellulitis
Yes, sir.
with a very bad outcome, very septic patient. And it's spontaneous perforation of the extraperitoneal part of the rectum. So it is not good news. Happens in very, very, very compromised individuals, unless it is traumatic, which is different. I'm talking about the one which is associated. Say even tuberculosis of rectum has been, taken as a cause. So if I have to put it down in the order of importance, it can be inflammatory bowel diseases. It could be tuberculosis. It could be even MBBS, but not common. It could be associated ulcers in HIV, human immunodeficiency or a virus-related disorder, that is AIDS, or the problems related to the lower part, which are extension of the colonic part. So it could be extension of the colonic and the sigmoid part. The rectum part. Now, you heard some sound?
Yes.
The stoma is functioning. That's what is it? What do you say for the passage of Flatus, an old saying? What is embarrassing to the Duchess is music to the surgeon's ears. So it's an embarrassment for a Duchess. The Duke's wife is the Duchess, right? So it's kind of a semi-queen. Dukes are like, we used to have Nawabs. There's a Nawab hote the Dukes. So it's embarrassing to a Duchess, but a music to the surgeon's ears. So if this sound bothers you, then you are in a wrong field. It may bother a psychiatrist, it may bother a physician, but the surgeon is happy, patient is moving his bowels. Right?
Yes, sir.
So why was ileostomy done?
So since it was in the upper rectum, so as the operating surgeon, I thought it should not be under tension. So that is why I created an ileostomy. Plus, patient was sick. The Parcher score was very poor. So that's why.
Okay. So now the diversion is fine. You had repaired the rectum, so you didn't want it to leak. So you did a diversion ileostomy, if I may call it. That's a diversion
Yes,
ileostomy. Correct?
Yes.
Yes. So why not a diversion colostomy?
so could have been done.
Which one is technically easier?
Colostomy, ileostomy.
Actually, which one is technically easier to do, to close, to handle, to manage? Is the ileostomy. The problem is the ileocecal wall, which should be made incompetent, so that you don't have the blind loop. That is what I was asking. When you're doing a colostomy, which colostomy you can do?
Sigmoid colostomy.
Okay, sigmoid colostomy is an option, and that is not so difficult and not so complicated. If I ask you, what would have been the advantages of doing it?
So sigmoid colostomy is much more physiological. So, the electrolyte losses and the water losses are less compared to the ileostomy. So, and the irritation skin irritation that would cause through a colostomy is much more less
Easier to manage.
Easier to manage.
What is the problem?
Difficult while closing colostomy closure is much more technically difficult than ileostomy closure.
Well, so in all APRs, low anterior resections, etc., people prefer to do ileostomy for another reason. For another reason, that is, if you were to mobilize this colon down for some procedure, you have the colon available. If you've done a stoma, that mobilization won't happen. Have you understood what it was? So it was in the context you should understand. But sigmoid colostomy is definitely an option. It is immediately proximal. The contents are all solid. The electrolyte loss is nearly negligible. It's a physiological thing. The peristomal complications are limited for the same reason. Electrolyte disturbances are limited. But you do not know whether you would need to do some procedure on the left side where you may have to mobilize the colon. But one can argue for and against colostomy comfortably here. Both are good options. Now it depends on whether the surgeon is comfortable doing one or the other. Otherwise, remember, the best diversion happens immediately proximally. The sigmoid colostomy would have been a good diversion, but naturally, you need to take a call on the table. Ileostomy is so quick, you can just bring it out, and it's far away from the area of contamination. So not likely to get any worse later. How is the patient doing today?
Patient is vitally stable as of now. Right now, we're managing the burst abdomen. Otherwise, and also the blood parameters, sodium is on the lower side, for which correction is being given.
Why do you think you, the registrar, are responsible? Why do you think this patient has developed burst abdomen?
Patient-related factors or the technique-related factors, but patient-related factors were that
So naturally, it's a poor score.
The patient was on triple inotropic support post-operatively. He was in ICU, NORAD vaso and DOPA.
Patient was not too fit
Yes, sir.
for the kind of procedure that we do. And the burst abdomen is the least you could get away with. In these cases, even if you leave the abdomen open, there's no problem. And I think you go close the sheath and leave the skin open, that is fine. And you can manage the the problem only when it is a living problem. Living problem is better than a dead solution. So this is an option that was exercised. Okay?
Yes, sir.
So when do you think we should close this divergent ileostomy, Vikotso?
So for this depends on the condition of the patient. First, we'll build up the general condition of the patient, and in 4 to 6 weeks we can plan for closure. Sir.
Based on the improvement in the general condition, and you would like to see the rectum is healed. Now, what is it that you would like to do as a definitive movement towards finding out the problem and fixing it?
The colonoscopy can be used to evaluate the colon and see if there are any lesions,
Whole of
any
the
ulcers.
colon for any inflammatory bowel disease. And even when you're closing this perforation, I'm sure the biopsy was taken. So that biopsy report has to be followed. It has come out as,
So biopsy report is awaited.
so it's awaited. The histopathology will let you know whether it was an inflammatory bowel disease or not. In most cases, you will find nothing conclusive unless it's a malignancy, which should be excluded. And this patient, once the patient is fit, you should do a colonoscopy because ileostomy won't be bothering you. So that's another advantage of doing the procedure. Otherwise, if you had done a sigmoid colostomy, you could do it through the stoma also. But the rest of the colon needs to be assessed for why did he develop perforation should be the next question in your mind. When the patient came with perforation peritonitis, you didn't have a choice but to manage by doing the procedure that you did. But later on, you need to find out the reason for the patient developing the perforation. One last question. Now, when you're dealing with such a case, how would it matter whether it is in the upper 1/3, lower 1/3, or middle 1/3?
Sir, upper 1/3. Actually, the upper 1/3 has a very good peritoneal reflection, and the supply is good, sir. We can, if it is traumatic, we can just freshen the margin and anastomosis. And the problem comes in the lower, because the accessibility is so challenging, sir, while assessing the perforation, and the supply is poor, sir. So we need to take care of that.
Now you can see by getting close. I don't know whether you can see from there. You can come in here if you want. And this is the pubic bone. That's the spine. This is the lateral section of the pelvis, right? This is the rectum. And it's a male, so we are not bothered about the uterus. The peritoneal reflection happens like this. And that's the anterior abdominal wall. This is bladder. And this is the cave of Ritzius. You taught this, right? Correct? And now the peritoneal, the floor. Okay, yeah, that's better. Now this peritoneal reflection is a little deeper, and this goes down as fascia of Denon Villiers, and this becomes this is fascia of Denon Villiers, this is spine. This is perineal body.
Yes, sir.
And that's the peritoneal reflection. That's why when we go in this plane, we call it going between wind and water. So this is wind, and this is water, and that's a fascia of Denon Villiers. Waldes fascia is here, and this is the lateral section, and this is the cave of Ritzius all clear. Now, the perforation here would behave like any intraperitoneal perforation. Will do well. The problem is here. Solitary ulcer is usually posterior, as you rightly mentioned. This is, and it is therefore linked to further lower to the direction of fecal matter going. But it's usually seen in anxious individuals. There are many factors which, and that's the perineal membrane. So you know the floor and everything is covered. Here, all of them will produce fasciitis, cellulitis, pelvic cellulitis, and create all the ruckus, dangerous. And they can present as fistula later on, multiple fistulae later on, and they can be multiple fistulae nano also. So what are the causes of multiple fistulae nano? Remember the K's: Cox, crush with K, cancer with K, and Crohn's with K. So Cox, crush, cancer, and Crohn's common. Exclude these conditions, and also exclude them anyway by when you're taking the history. Okay, so that's about it. Finally, if you have done a repair, since the perforation was here, it is always good to divert, and diversion is usually ileostomy. You know what? This area would be all contaminated. So getting a sigmoid out is not a great idea also for this reason. But I've already told you why taking sigmoid out has its advantages and what are the disadvantages. That part we already discussed. Multiple fistulae nano, Cox, crush, cancer, and Crohn's. Exclude that. It is seen that amoebic colitis, can it have proctitis? We don't know along with it. Not common because the wall is very thick, but in immunocompromised individuals it can happen. Can it be a cancer? Yes, it can be a cancer. So these are the. So when you're looking at treating these patients, don't just stop at managing the perforation peritonitis, which you have done. You already managed that. Now we need to go beyond it to find out the etiology, fix the etiology. What would you do suppose it comes out to be inflammatory bowel disease?
So we'll have to start on medical management. Steroids we have to start on.
First we will confirm it is ulcerative colitis or Crohn's disease. So there is
Colonoscopy.
various investigations that can support. There is nowadays genetic analysis also, and some proteins, RNA proteins, and followed by there is a group of drugs that can prescribe separately for
So
ulcerative.
before you put the patient on any definitive therapy, you need to run your all investigations, like again to confirm the diagnosis, to support the diagnosis, and also to find out the genetic basis to it, because there is a genetic basis to it. For ulcerative colitis, you have drugs like celazopirin. Steroids are for Crohn's. How long, when to give? Exclude tuberculosis. What can you do to exclude tuberculosis?
So tuberculosis in biopsy we can pick tuberculosis, and tubercular workup we can do additionally.
I'm
because it
asking
is-
specific
First we
workup.
rule out the pulmonary because it's always secondary to the
So
pulmonary.
always
part.
exclude a primary tuberculosis
Yes.
to rule out a secondary. But GI can be a primary tuberculosis also. Rectal can also be primary. But histopathology or the biopsy can show you the granuloma, the Langerhans, giant cells, caseation, necrosis, and all those factors which help you make the diagnosis should be done. Then you can do the gene test. What is that?
Gene expert test or so similar.
The gene expert test would be what?
Gene expert test is used to detect the MTB RNA in the lymph node.
Yes, yes.
It can be used for any. It can be used for
Polymerase
sputum
chain
also.
reaction. It's a PCR. So you'll exhaust all your investigations to rule out tuberculosis. Why is it so mandatory? I mean, why is it so important to exclude tuberculosis before you put the patient on steroids, Surya?
Said
The chances of
Terry?
flare up is more.
So, if
Yes.
Chances of
Sabir,
flare up,
right?
TB
They're
flare up
wasting
is
time. It's steroids. flare up the tuberculosis, even the latent subclinical tuberculosis would flare up, and you can actually produce disseminated tuberculosis. So you should not put the patient on steroids empirically. And in any case, the empirical use of steroids is out now. You must have heard of therapeutic trial for tuberculosis. We have given it also in the past. What was the therapeutic trial? You put the patient on ATD. If the patient responds, it is tuberculosis. That's like putting somebody on anti-amoebic treatment. If he is feeling better, then he has MBBS. All Indians have MBBS. And almost all Indians have tuberculosis also. Some bit of it, subclinical. So they will respond. But that doesn't make them tubercular cases. And now therapeutic trial is out completely. It's obsolete. There is no exception to the rule. You need to establish tuberculosis before you put the patient on ATT. For rectal tuberculosis, Terry, what should be the ATT of choice?
So the HRZT is min only, sir.
The category 1
I couldn't hear anything.
Sir, category 1 only, sir, is now it's the same. Only category 1 and category 2.
Duration?
So 6 months.
So that confusion about abdominal tuberculosis, duodenal taking a different, bone taking different, is no longer valid. Because it's the same disease. The problem used to be the vasculation, supply. Any other questions? Anything?
Patients and the suspicion of traumatic perforation is very high. Will we still be doing the workup like colonoscopy,
No, high means you have to establish it.
Suppose there is a perforation in the rectum, even high up, without the injury in the perineum, is it possible? So there may be some either pathological disease already pre-existing, so that the minor or trivial trauma
That's
can
an
lead to
important
the-
point. Trauma in isolation happening exactly at a particular point in rectum is not common. Having said that, if you suspect trauma is a very important factor and we could not exclude it for whatever reason, you need to exclude it. And then if you have excluded it, you need to find out the pathology behind. Rectum does not perforate easily. Rectum does not perforate. The easiest is duodenum, then is the ileum, then is the colon, then is the sigmoid, part of colon, then is the rectum, in that order. And don't argue that, we had one case where everything was fine, rectum is perforated in one case. If the patient has a disease there, underlying disease can cause perforation anywhere. Sometimes there is a stricture distal to it, proximal part perforates. That also is a known thing. In tuberculosis, perforation is not an immediate presentation. Perforation is usually proximal to where the obstruction is. Due to obstruction, the proximal part is dilating and it dilates so much that there is ischemia and it gives way. These are the possibilities.
Boy who had an LH history of blunt abdominal trauma 5 days back, presented to emergency with abdominal pain and abdominal distension, and also patient at that time had on an examination, patient had an abdominal tenderness with guarding, for which we did a routine investigation, and he also had a gas under diaphragm in the chest X-ray erection, for which and then we resuscitated the patient with fluids and IV antibiotics, and then patient also preoperatively his aperture was less than 10, and after that on intra-op finding, patient had a perforation of 1 into 1 centimeter at 1.5 feet from DJ in the jejunum, for which we did an resection and anastomosis for this patient. Right now, patient is vitally stable, and patient has been allowed oral sips. Patient is passing slightly sensitive, bowel sounds are present, and has been allowed oral sips for this patient.
Why RA? Why not just close it? What was the reason?
So there was some ischemia around the perforation, so that segment of around 5 centimeter was along with the perforation.
So actually the perforation was exactly at the mesenteric side, not the anti-mesenteric side. So the area was very dicey, so I had done
So the reasons for perforation being, I wanted that to be highlighted so that there is no confusion. You don't know do an RA, but if a perforation happens on the mesenteric side, then the blood supply could be an issue. And we need to be careful that just closing the perforation should not be your approach, because you're likely to then mess up. This is the bowel, that's the mesentery. Most perforations are on the anti-mesenteric side because of the poor blood supply. So they are not an issue. We don't resect that segment. But if the perforation is here, I am worried about the blood supply because mesentery supplies the gut. Which side is more important? The mesenteric side. Repeat. Why? Because the blood supply is coming from this side. Okay. So perforation here is not the same as perforation here. This perforation can be closed. But this one, we are worried. So that's why the resection had to be done. And see, I am putting my resection in such a way that there is more of mesenteric side available because that's supposed to be the blood supply. Don't put it the other way around. I think it's there in my videos on basic skill. Never put it like this because you'll have more of
And least perfused.
least perfused part. I would want more of perfused part. Is that clear to you all? Everybody is clear on that?
Yes, sir.
So when you're applying these clamps, don't put them in this way. They should be put looking at each other, not looking away from each other. The tip should be looking towards each other. What should be? The tip should be this way. So that we have more of when I'll just try and do some stunt here. So after I've resected, I have more of the mesentery. Now they can be then anastomosed. That is the purpose. Apply the clamp. Now back to the case. Close to DJ. So what are the options?
So depending on the Apache score, we would decide. If the Apache score is less than 10, definitely we can go ahead with primary closure or the resection anastomosis. But if Apache score was in the category 2, then we would have exteriorized and we would have done a jejunostomy. And
With its inherent problems. Because it will be a very, very high output stoma. So, your take, how do you, one is objective criteria of doing the Apache 2 scoring. If the score is less than 10, it's reasonably alright patient. Don't go by contamination. This is subjective. One finds it contaminated, the other may not. So that is one. The other thing is
exteriorizing.
So what are the options, sir?
So we can make feeding jejunostomy along with, in case if it fails, we can have the bowel for the feeding. And sir, if it is very close to the DJ, then an Apache is good. Sir, we can just divert it by doing the gastrojejunostomy also, sir. We can bypass the segment and we can do it.
Rishi, what would you like to tell them about the DJ, close to DJ perforation, say within 10-15 centimeters?
So can we do triple tube, primary repair with triple tube? Sir?
See, the argument is basically whether it is going to bother in terms of healing. If it heals, nobody is bothered. But as you move from duodenum towards jejunum, the blood supply keeps on improving, but it's not the best. Because you have segmental supply for the jejunum. Gradually the mesentery takes over, and then you have the mesenteric supply. So there's a better supply of the ileum than of jejunum. They tend to heal poorly. Plus there is more tension in all junctions. The DJ is fixed, jejunum is moving relative to it. So it's not a stable place for anastomosis to heal. And if it leaks, it's a disaster. So that's why there's so many things that come to your mind. One is if the patient's score is bad, it's not expected to heal. It is better to exteriorize it as a stoma. If you think it is going to heal, but you're 50-50 about the pressure on it, then you repair it. You can do a distal feeding J also. There is no harm, because that decompresses that reduces the pressure in the jejunum. This is what we practice. Plus, even if there is a leak, we have a distal access to the rest of the gut for feeding. Whatever leaks can be put back into the jejunum as enteroclysis feeding. So that takes care of it. The third option is you can do the repair feeding J and a gastrojejunostomy. If the patient is fit for a repair, then fit for diversion also. So that will be more of a diversion, allowing it to heal like you did the diversion ileostomy for rectal perforation. Triple tube is a procedure mostly for the duodenal injuries. For jejunal injuries, it may not be a very good idea. Can be done, there is nothing like one method of dealing with it. But jejunum is not like duodenum, it tends to heal well. But if there is a risk, you think you're 50-50, suppose the score is 10, you can go either way. But remember the dictum which I have taught you, whenever in doubt, take it out. Because you can live to fight another day, you can close it quicker. Take care of the output for some time, and within 2 or 3 weeks, you can take it up for closure early. So early closure needs to be done, otherwise they tend to cause a lot of problems. But if the score is bad, there is absolutely no reason why you can't exteriorize.
Bowel, most of the time we need to exteriorize rather than doing the primary anastomosis, because it usually leaks on most of
That's what I'm
the
saying. So if it is a pathological bowel, the score would be bad. I'll go by score, otherwise there is some confusion. There can be a traumatic bowel which is worse than a pathological bowel also. So they all reflect in the Apache 2 score, that's what our publication is. Once you're going by Apache 2 score, you don't worry about the etiology.
And especially in
Otherwise it's very, very subjective.
especially in trauma, as per ATLS guidelines, there is a serum lactate, serum bilirubin. There is a criteria for damage control surgery and early total care. So if patients falls in the category of damage control surgery, better to perform a damage control surgery rather than doing the definitive surgery.
And what would be the damage control surgery in a trauma of jejunum?
It's just a diversion and
Taking care of the
Exactly the same.
contamination.
So,
Yes, sir. It is
you
like
do the exteriorization. So it is another way to standardize or triage your patients so that you don't do too much. Are you following? Because if you do more than the patient can handle, your treatment could be excellent, but the outcome is poor, which is not good news. So whatever treatment you offer should benefit the patient. And second thing you should remember, it is given in the beginning of your Hutchinson, a Hippocrates statement. Primum non nocere. Above all, do no harm. Can you repeat?
Above all, do no harm.
So, repeat again.
Above all, do no harm.
So you do what you can do, but don't hurt. That is primum non nocere. Remember this as a principle of managing any patient anywhere. The outcome of the patient is indicative of the correct decision taken, because you could have landed up in, if the leak happens, you're in trouble. And of course, we leave the skin open because we expect anaerobic contamination, and the patient is doing fine.
Yes, sir.
So, like I said, you should live to fight another day. Don't die that day or don't kill that day. Get ready for the next thing, and that is what is bailing out surgery, as Dr. Rishi just mentioned. You bail the patient out and bail the surgeon out also. That is, the surgeon also needs to be bailed out of that chaos, because he is working in a very tight environment, contaminated field, limited resources, limited expertise. Everything counts. So the procedures that you are saying, triple tube or diversion, they all should be done at a time when everything is falling into, within a normal range. What is the fluid order for today, and how did you decide that?
So right now we are giving a total of four weights based on a patient's weight, sir. The weight is 30 kilos for this patient. So based on that, we are giving a total of 4 weights, 2 D5 and 2 RL is being given, sir.
Any difference of opinion, Ayush?
So the patient has been allowed only since yesterday, but only oral sips have been allowed. So according to that, we'll measure the urine output and and the insensible losses, and according to that we can calculate the fluid that has to be given to the patient.
How would you calculate the fluid?
Sir, sir, based on the weight, sir, it is given. Sir, for a 70 kg man, it's usually 2.5 liters, which is already considered the insensible losses and the normal urine output of 0.5 ml per kg per hour and the stool losses, sir. And sir, since this patient also has a stoma, we will take that also into account. If the patient has vomiting, that will also be taken into account. And maybe sometimes per rectally also they discharge. That will also be taken into account, and that will be added to the total of 2 liters that we are
He is
giving.
giving D5 only. What about the Ringer's lactate?
So
at this
he
point?
sir 2 D5s and 2 ringer lactates, sir.
You're
Sir,
giving?
So 2
so 50 grams of glucose is
Why
going.
Ringer's lactate at this point?
So there might be electrolyte imbalance for this patient. So we're given
Which electrolyte is especially important in this patient?
so potassium is
Very good. So we need to make the bowel move. Potassium is required. And following muscle injury and overall trauma, there could be a rise in potassium also. Should be careful. Don't infuse too much. Ringer's lactate has an advantage of the pH being alkaline, and the patient is more physiological, matches the blood pattern, plasma pattern. So we would be giving that. What about the supplementation? Any nutritional supplementation required?
Yes, sir. I would like to put the patient on potassium supplementation since he has just been orally allowed.
I'm talking about nutritional calories.
Calories, sir.
Dextrose. So because if the patient is NPO, the 2 things we need to care of: water and the food. So for the water for the NPO patient, the saline, and the food is the dextrose. So we need to titrate. We need to chart the fluid as such. The patient will get adequate amount of fluid along with the saline, electrolyte, and the calories. That is dextrose, sir.
So we'll switch to oral, or the enteral nutrition is superior to parenteral nutrition, right? So why is it superior to parenteral nutrition? For their benefit, can you rattle it out?
Sir, internal nutrition is more physiological, sir. The gut viability is there. The villi atrophy is lesser, and opsonins are secreted, sir. IgA and IgDs are secreted. So
And enterohepatic circulation is maintained. And more physiological, the chances of transgut migration doesn't happen. Villus atrophy because of that not happening. And then we don't have the, we don't have the stasis of the bile. Cholestasis doesn't happen because gut is moving. So these are all advantages. When you have guts, use them. Guts, use them. Use them or lose them. Even otherwise, right? So guts, use them or lose them. That is what we need to do, and that is how we will make up. How do you prevent DVT in this patient? What are the chances, probabilities, and what would you do?
so for this patient we have to make sure that the patient is immobilized, and also foot massage, lower limb massage can be done from there. And other than that, we can if the patient has if the patient has symptoms of DVT, we can get an ultrasound.
So according to the ERAS protocol, patient has to be ambulated as soon as possible. So on post-operative day 1, patient has to start walking, and limb physiotherapy has to be taught and should be done daily to prevent any.
The role of heparin.
Sir, it should be based on the modified Wells criteria, sir. Based on that,
First
Therefore, speak that out.
First
Finish.
stratify the score, then consider for this.
yes.
What is the criteria? Yes, finish
Sir,
that.
based on the modified Wells criteria, sir, there's a scoring system that has been placed. Based on that, we'll decide whether the patient needs pharmacological prophylaxis or not, or just the mechanical prophylaxis. In case pharmacological prophylaxis is required, then we start on the low molecular weight heparin, say enoxaparin. So patients who have undergone major abdominal surgeries, who are who would require immobilization for a very long time, would be started on pharmacological prophylaxis.
What is the Wells criteria? You heard it, no? Wells criteria?
There are 6 or 8 criteria for risk of DVT, and further there is a risk of, if there is a risk of DVT, then there is a further risk of pulmonary venous embolism. So both criteria, Wells criteria is specific for DVT as well as the pulmonary embolism. According to criteria and scoring system, you will just describe the medicine or
Which
just
criteria we talked about, Atul? What did you hear? What was the significance of it? You want to prevent what? DVT. So that it prevents pulmonary embolism. And in any patient who is lying supine or has undergone surgery, abdominal surgery, especially pelvic surgery, or a patient who's
prolonged immobilization at
patient on chemotherapy, or on cancer patients, obese patients,
Previous history of
patient on
thromboembolism.
previous past history of thromboembolism, and patients who are on prolonged immobilization like fractures, etc. That is very important. So is this patient is young patient, not likely to get it, mobile, his limbs are moving, He's moving around. So if you take care of it, pharmacological prophylaxis or pharmacoprophylaxis is not indicated. That was the question. Clear record, sir? So you were right in saying that we have started with the early mobilizations. We are doing the calf pumping. We are making the patient walk around. Do you know the other factors too, like hypothermia? Not in this weather. If you complain of hypothermia in this weather, there is a serious problem, right? Delhi is boiling. So hypothermia, prolonged immobilization, prolonged surgery, underlying conditions like obesity, cancer, chemotherapy, steroid therapy, all these contribute. So take into account everything. That's why Wells criteria is into place. And we will use Wells criteria to take a call. In this case, it is not required. That's what I was trying to ask you. So you should know when to use it to prevent deep vein thrombosis from happening. You mentioned if the symptoms develop, we will do something. So what symptoms would indicate deep vein thrombosis? I think I'll ask somebody else. Yes, Sabya?
Yes, sir. There may be calf pain, sir. Calf pain, active as well as passive calf pain will be there, sir.
Okay.
Unilateral acute lower limb pain,
Sudden onset pain
without any history of trauma in a non-ambulatory patient should raise a high suspicion of DVT.
So, but if he had a history of trauma two weeks back, in the context that you're saying, unilateral, spontaneous, sudden and acute, they both mean the same, sudden and acute. But bursting pain. And then you have two signs, Homan's and Moses sign. What is the Homan sign?
Passive dorsiflexion of the foot will cause tenderness. Ankle will cause tenderness in the calf region. And Moses sign, there will be squeezing of the calf muscle will cause tenderness.
So, which of the two is obsolete now?
Moses
is obsolete. Who was Moses? Nikotso?
Moses was in Old Testament. He was a prophet.
He was a Jew, prophet. Now Judaism starts with him, although they are part of the Abrahamic religion. And he crossed that desert with the Jews when they were banished from Egypt. They crossed Nile later, but they crossed the desert, reaching the Mount Sinai, which he climbed up to see God. That fire and taking off the shoes. That story is related to Moses, right?
Yes.
Because if you don't know what the fire is for, you won't take off your shoes. But he also walked in with shoes on. And when God told him, take your shoes off, you're walking into my territory. So he took the shoes off, walked in. And he crossed the desert along with all the Jews. And it's believed that with his staff, I don't know, there are many stories. This pain would happen in the calves if you prolong walking. Touching of that staff, the pain would go. What I'm saying is, Moses' sign was squeezing the calf would produce severe pain, but it can dislodge the thrombus, so therefore, not done. 2, it is painful. I think first one is more important. There is no point doing it. And Homan sign is non-specific. So you rely more on Doppler now. Ultrasound is an extension of clinical examination. So both these signs that you are asked in your exams, Moses sign, Homan sign, they are more of theoretical importance to somebody who is too fussy about it. Otherwise, we will need the method to find out is using a Doppler, looking at the flow. There can be increased tension in the compartment. So patient may present with compartment syndrome also, which is again the same. There is some bit of swelling and distal pulses may disappear, or the neurological deficit would start happening. Only with the nerves which are within the compartment. Be clear on that. So it should be noticed immediately. A very common situation, patient underwent a major surgery yesterday and in the morning is having tachypnea and is blue. You should think of pulmonary embolism. Pulmonary embolism should come to your mind instantly. And how would you make a diagnosis, Gokul? You are the resident on duty in the ward.
Yes, so pulmonary embolism can be diagnosed by X-ray. ECG can show a pulmonary embolism. And
how will ECG show pulmonary embolism?
Sir,
S1Q3 pattern.
S1Q3 pattern, sir. On the X-ray, on the ECG will
other features.
on CT pulmonary angio we can do, sir. That is investigation of choice.
But on the bed, what do you do?
The patient will have tachycardia, sir.
Obviously, tachycardia, tachypnea, raised JVP may or may not be there.
Based on acute or subacute pulmonary embolism can be of two types. Based on acute, there will be hypotension also. With the hypotension, tachycardia, raised JVP will be there. And subacute pulmonary embolism, usually cardiac compromise will not be there. There will be only tachycardia is present in the subacute pulmonary embolism.
So sudden onset respiratory distress, which is not improving with oxygen therapy, can point us towards pulmonary embolism bedside.
To add on central cyanosis, sir.
I think that's an important point. Central cyanosis, tachypnea, hypotension, with or without raised JVP, because that's a feature of right failure. JVP would rise and the heart is not taking the blood, right side. And there is a preceding history of something that has happened. It doesn't happen very often spontaneously. It would have some precipitating cause. What do you do? Firstly, believe it is there. Don't wait for that CT angio stuff. Otherwise, what is the gold standard investigation?
The CT pulmonary angio.
CT pulmonary angio. Any role of Swan-Ganz catheter? Used to be there, the pulmonary catheterization, getting the actual wedge pressure, which used to be
Only theoretical, sir.
right? So it used to be the gold standard, it remains the gold standard, and it is not theoretical. This is invasive. That's the only problem, and you won't be doing it at this point of time. Okay. So the other thing is, immediately put the patient in what position, Ram?
So, put the patient in reverse tunnel or position.
That means head and up.
No, sir. So it's tunnel or position, sir.
So don't have Durant position is what we prefer. DURRANT. Which position? Diksha? There used to be a Durant tournament also, no? That is different. Football tournament. So don't get confused. That is D. This is Durant. How do you define it? What is the position?
Right lateral and with like head and up. So
See the problem, the reason. First of all, understand why Durant position. You want to close the ostia, and you want the air to go to the foot end. So if you keep the head up, the air will go into the brain. Dangerous. So foot end up, turn to the left. When you turn to the left, the ostia get closed. Coronary arteries, there are ostias, no? Ostia have to be closed, and they are closed in that position, so that the air doesn't get into the coronaries. You don't want the air to go into the brain also. So we turn to the left and put it down. This position is commonly discussed during laparoscopic surgery because of embolism that can happen. And the anesthetist will tell you, you will tell the anesthetist it's looking like bleeding more. The anesthetist will check the saturation and tell you, no, please stop it. Because one of the complications that used to happen, and the position has to change. Is that clear?
Yes.
We put it in the head down position, easy to remember, turn left. What is the other name for this kind of a position?
Is it recovery position?
Louder?
Recovery position.
Recovery position. Tonsillectomy position. Post tonsillectomy, they would keep it in this position so that you don't need it anymore, but you should know all this. But importantly, don't mix up Durant position with ton. Please don't misunderstand and try to use them alternately. I'm just telling you so that you can remember both positions. The position is head down, foot up. If head is down, foot is obviously up. To the left, turn to the left. So right up or the left down is the same, no? So 3/4 prone to the left side. So that is what you do. And you need to put the patient on heparin therapy and thrombolytics.
This patient is NPO since 3-4 days. So how will you monitor? This patient is nil parosma. So every morning, how will you monitor this patient, especially by the first year residents?
I think that will Fluid you want?
Fluid
You cover.
Fluid overload and
You
hypovolemic.
रुकते हैं इधर, नहीं तो I have to go. रुकते हैं बोल रहा था. You understood about the Durant position and associated problem. What Dr. Rishi is asking is the fluid every day. They have answered partly on day one. Quickly answer. One of you can answer.
What are the sign of hypo and hyper? Fluid overload and
What will be the first sign feature of hypo?
Sir, in case of hypovolemia, we would look for the mucosa of the mouth, sir. If it's dry, we are suspecting dehydration in this case. Urine output as well if it's low. So we input output starting to become the release sign
fluid
hypovolemia.
overload.
Fluid overload, sir, patient will have sir, weight gain will be the first sign. And then patient will have bilateral crepitation.
So basically, basal cracks, confused mind, especially in an elderly person. Remember, because confused mind will be in hypo and hyper both natremia. Fluid overload is hyponatremia. If there is more fluid means less fluid. So features of hyponatremia will also show up. Increased weight, but importantly basal cracks. Right? And even without doubt, you can start the patient on diuretics immediately, but rule out some cardiac reasons. So don't try to be, a hotshot surgeon managing it. Okay?